So thank you very much. I just wanted to express my really gratitude for being here, and it's a great meeting. And the work which you do, I mean, both institutions, to get people together and to create an international network is really fantastic. My topic is locally advanced and distant metastatic disease, frontline treatment, the first line treatment. And these are my declarations, not that long and Brad or Rob. I will separate these two topics, although these two groups, locally advanced and primary distant, usually are put into one pot in clinical trials, but both groups has very different prognosis and also differ in the management. So starting with the LAC. And in the LAC, in the locally advanced disease, we have to first define what's the definition of the LAC, because by definition, it's the disease which is confined to the pelvis, but outside of the cervix. But if you look at the routine practice and also to some guidelines and also to some clinical trials, there is an overlap. And this overlap is enlarged 1B tumors. So typically 1B3 tumors are very often put into one box into the locally advanced disease. So there is a kind of overlap between early stage and locally advanced disease. Is there any role of surgery in the management of locally advanced? This is one of the algorithms from the European guidelines, the update, which is just accidentally going to be published next week in the International Journal in Radiation Oncology Journal. And there is an option as a radical surgery, radical hysterectomy combined with pelvic lymphadenectomy in 1B3 to A2 tumors, so larger than 4 centimeters. It may be viewed for some of you, definitely for Brad, as against current recommendations, and indeed, even NCCN guidelines claims that 1B3 tumors level A evidence support chemoradiation better than other treatment options. And it's based on a lot of references. Actually, there is only one randomized trial, and it is old Italian trial from 80s, which truly randomized between radical surgery and chemoradiation. There are a lot of things which reflect the clinical situation 30 years ago. But even in a Landoni trial, there was no better outcome of patients after chemoradiation. The groups, the outcome was identical, was the same, even in patients with large tumors larger than 4 centimeters. And all other papers, which are usually cited as an argument for chemoradiation being better than surgery, are actually randomized trials comparing radiotherapy versus chemoradiation. There is no arm, single arm for a surgery. What I would like to highlight is that the tumor size, although we know that it's a traditional, typical risk factor in cervical cancer, is not that key prognostic factor. Let me use this example from the SCAN study. The SCAN study was a collaborative retrospective, huge work, more than 4,000 patients included. And let's play it with the data a little bit and select only patients with negative other prognostic markers. So negative lymph nodes, grade 1, negative LVSI squamous cell. And if then you compare the outcome of patients below 2 centimeters, 2 to 4, larger than 4 centimeters, as you can see, there is very little difference in the outcome. It corresponds to another aspect of the SCAN study, which we published just recently, because we looked at the data about the treatment. All of them received primary surgical treatment. The treatment of 1B3 tumors, so patients with tumors larger than 4 centimeters, there were 300 of those patients. And not only was the overall survival over 90%, and there is a long-term overall survival of 5 years, but also there was no difference in the outcome between those who received or did not receive adjuvant treatment. So of course it's retrospective data, but it's the data showing that surgical treatment can be a valid option even in those tumors which are bigger than. What makes the tumor size so much linked with the prognosis is mostly this one. And this is the increasing risk of lymph node positivity, which indeed correlates very closely with the stage and with the size of the tumor. So it's between 7 to 10% usually in tumors below 2 centimeters. Let's see what will be the SHAPE trial. But it can be between 30 to 40% in patients with larger tumors than 4 centimeters. And this is why in the guideline it's emphasized that there should be some reflections trying to avoid doing surgery in patients with positive lymph nodes, at least 2 steps. First steps is before the surgery, clinical staging. So the guideline says that one of modern imaging technique is mandatory. Golden standard worldwide is MRI, but it has been shown in already quite a few studies that ultrasound in expert hands has equal outcome, equal accuracy than MRI in local staging of cervical cancer. And the second step, and this is one of the biggest advantages of sentinel lymph node biopsy, that during the surgery we identify 2 or 3 lymph nodes, which we know are the most important lymph nodes in the pelvis. We can send them directly to pathologists, and they can do frozen section. So this can be another step which identifies another at least 50% of patients with positive lymph nodes will finally be positive out of final pathology. So after these 2 steps, if they are done properly, the risk of having at the end of the management radical surgery and positive lymph nodes from final pathology is less than 10% in the group of early stage cervical cancer. What's the role of neoadjuvant chemotherapy followed by surgery? Well, there is no such recommendation in the guidelines because the international group felt like there is currently no such role for neoadjuvant chemotherapy based on data from many trials in the last 10, 15 years. Just mention, we don't have time, a Japanese trial which was prematurely terminated, not because of slow accrual as GOG trial, but this was terminated because of the inferior overall survival in neoadjuvant chemotherapy arm. And recently, the study led by Tata Memorial Center in India, showing indeed better PFS, but no benefit in overall survival. So neoadjuvant chemotherapy, obviously, can decrease the shrink, the tumor. It can also make disappear some metastasis in lymph nodes, but it cannot improve the final survival of patients. It's out of question that the whole field of locally advanced disease is ruled by chemoradiation. There have been several studies within the 90s, and this is one of them. I've already showed it, testing radiotherapy versus chemoradiation, or this one, another study, and all of them uniformly showed that chemoradiation is better, is beneficial in comparison to radiotherapy, combined radiotherapy only. This is in a adjuvant setting in high-risk patients with positive lymph nodes or positive surgical margins. The previous one was in primary treatment. Radiotherapy is typically a technological driven field. So it's continuously developing and it's continuously improving. And that's why the new data are so important and so interesting. And Embrace one trial was interesting for other aspect. It was a prospective, not randomized, observational study, but in highly selected sites with very highly standardized chemoradiation. All of them used planned MRI-based brachytherapy. And in this study, they also included patients which would traditionally be referred for primary surgery, 1B1 patients. And as you can see, although it's very small, the local control was excellent, although the survival, the 5-year survival, was only 76%. But at least these data show us that indeed chemoradiation is an alternative option to radical surgery in these patients. What is striking is the local control across the stages. So you see that there is 90% local control even in stages 4A and 4B. At the same time, 5-year survival or disease-free survival is below 50% in these patients. So it shows us that local control is perfect, but these cases who will later recur are either distant failures or lymph node failures. What about immunotherapy? There was a big expectations from immunotherapy in this field because, as you can see, in the higher stages, the probability to cure the patient is less than 50%. So there is indeed still a need for further improvement. Unfortunately, as you probably know, at the CALA trial, there was a really huge expectations from that, combining immunotherapy with chemoradiation and following with further maintenance treatment. This CALA trial was negative, and both progression-free survival and overall survival did not prove any benefit from the combination. So this is a big disappointment for our field. So this was a locally advanced cancer management, and now we move to primary distant metastatic disease. Current standard was more or less defined by the GOG 240 data with bevacizumab. The bevacizumab showed the benefit of about 3 months in overall survival. But still, if you look at the tail of these curves, after 3 years, there are very small subgroup of patients who are actually surviving. So although yes, there was a benefit, yes, there was benefit for the survival, still it's a field of a huge need for future research. Keynote 826 was a trial which changed these standards for the first-line treatment of these patients. It used immunotherapy in this metastatic tumor setting in combination with standard of care chemotherapy plus minus bevacizumab and in further maintenance. And it was a positive trial showing a significant benefit in a survival of about 8 months. So if I mentioned bevacizumab of 3 months, this was 8 months benefit in the survival. And it is a biomarker-driven treatment because this benefit for the survival is present in patients who are PDL positive. So this is the evolution which we got so far. Definitely both bevacizumab and immunotherapy brought a benefit for our patients, but still the proportion of patients who are cured of the disease is not high. So standard of care currently, no doubt, is platinum-based chemotherapy combined with pembrolizumab plus minus bevacizumab. What I also like on the guidelines is this second step, which is quite rare, but can be very crucial for a small subgroup of patients. And it's the situation when after the systemic treatment, there was a good response, but at the end of the treatment, there is still some residual disease. It can be two situations. It can be complete response in the pelvis, but a residual focal disease in a distant localization, and it can be complete response distantly, but a persistent tumor in the cervix. And in this situation, we should consider always whether there is a place for further treatment, which is a focal treatment, can be ablation, can be surgery, or can be radiotherapy to either improve prognosis or to even cure patients. There is a very little published about oligometastatic disease and regional treatment in cervical cancer. This is one of the studies from China, 56 patients treated for oligometastatic disease. And you see that the local control in these patients was excellent. And also the overall survival after 3 years was quite reasonable, 50%. And as you can see here, tumor size, I mean the size of the oligometastatic disease, was the major prognostic factor. These are data from the SCAN study. Among 530 recurrences, 64 were long-term survivors, so they were free of disease after 3 years, and 24 of them had extrapelvic disease, abdominal, lung, or supraclavicular locations. So although it's rare, it's only 5%, it's 5%. 5% of patients who so benefited, they were long-term survivors after the deadly disease. The next chapter is what we can expect in a near future. Well, just 2 slides. This autumn and at ESMO, we highly anticipate results from another trial, phase 3 trial, CX11, testing the same strategy as CALA trial, combination of immunotherapy with chemoradiation parallel and in the maintenance. And there is another strategy to wait a little bit, not to give immunotherapy during chemoradiation, but only in a maintenance phase. And also this phase 2 trial should be presented at ESMO this year. So hopefully this can bring an additional increase in the survival of the patients. Finally, what is the pipeline? Because the pipeline in cervical cancer is pretty complex. First group, it's not one study, but first group is a combination of different checkpoint inhibitors. One of those combinations, the balstilimab and zalifrelimab, already received a positive response from FDA. Of course, such a combination, especially if CTLA-4 checkpoint inhibitor is involved, is associated with much higher toxicity. Another large group of products are antibody-drug conjugates. The most advanced is tisotumab vedotin, TV, which is antibody against tissue factor. And we have already from phase 2 some group in the first line, and the outcome was pretty promising, reaching overall a response of more than 50% if TV was combined with carboplatin. Another exciting group in cervical cancer is another immunotherapy group with active immunotherapy like TILs, adoptive T cells, which are grabbed from the tumor. They are cultivated, multiplied in the lab in parallel. The patient is lymphodepleted, and then T cells or TILs are back infused to the patient. One strategy combines TILs with IOs, with checkpoint inhibitors, and it already showed not only very good response, but a durable response, which is a very good signal for these patients. And my last topic are vaccines. Of course, therapeutic HPV vaccines must be the field and has been the field of a research interest. Unfortunately, these vaccines so far fail to detect epitopes of HPV infection on the cancer cells because they are well expressed on healthy epithelial cells, but not that much expressed on cancer cells. But even here, it looks that a combination of these vaccines with other immunomodulatory drugs like checkpoint inhibitors can bring a good efficacy. This is very heavily pretreated population and reaching objective response of more than 30%. And there were even patients with complete clinical response in this study. So in the pipeline, there is a lot. And in my opinion, the most promising are these three groups: antibody drug conjugates, combination of different checkpoint inhibitors, and active immunotherapy drug. So those are my take-home messages, which are slightly different from the algorithms. I wanted to emphasize that in each patient with locally advanced disease, we first should consider whether there is an option for curative treatment. And it's only at the beginning of the treatment, but also during the treatment. It can be chemoradiation, can be surgery, but it can be also after the systemic treatment in case of good response, but residual disease, local treatment for regional oligometastatic disease. Current first-line treatment for metastatic disease, no doubt, is currently platinum-based chemotherapy, combination with pembrolizumab plus minus bevacizumab, but 2-year overall survival is 50%. I cannot say only, but it's 50%, so there is still a lot of space for further improvement. There are emerging changes, probably can happen this year, and multiple promising strategies for the future. Thank you.
David, thank you for an amazing presentation. It really made me understand what an amazing evolution we've seen in the last years in systemic therapy. Me personally, I'm especially interested into your look into the future. You told us a number of therapies, ADCs and immunotherapy and adoptive TILs. If you would have to put your money on just one of those groups, ADCs, adoptive TILs, immunotherapy, what do you think is the most single promising of all the future therapies that you just put forth?
I wish, I would be able to do so. Then I would be rich probably in the future. But no. My choice would be probably immunotherapy for a short term and vaccines for a long term.
Are there any questions from the audience? And yes, please.
Thank you for the great summary. Regarding to the neoadjuvant chemotherapy, all the studies that we saw until today are without these targeted therapies like pembrolizumab and bevacizumab. So we are trying to to cure the patient, but we don't, I think, we don't take a closer look to the risks of the radiochemotherapy, the way the patient feels after the radiochemotherapy. So maybe we should find a way to do a neoadjuvant chemotherapy or treatment before a surgery to get a cure. And so we should test those new possibilities of targeted therapies in this way. There's too low.
Yeah, I can tell you my personal opinion, which is that I really don't see too much space for neoadjuvant treatment because it's always a combination of different treatment modalities, and it can even hide some risk factors. We somehow consider that if the tumor at the beginning is 6 centimeters and then it shrinks to 2 centimeters, then we operate 2 centimeter tumor. And I disagree with this. We still have 6 centimeter tumor. And the same is with lymph nodes. Yes, we have data showing that after neoadjuvant, there is much less rate of lymph node positivity. The question is, were these metastases really cured or just undetected because they became too small? And we don't know it. So I think, in the future we will have always at each patient to decide whether we will go surgically or non-surgically. And this is the way how we manage the patient. So if we go surgically, we try to do surgery and make surgery as the only and final treatment modality and avoid combination. And it might be easily in the future that if we have really curative treatment, which is systematic, well, then surgery will disappear because you will have other modalities, of course, based on comparison of toxicity.